We're excited to hear from Dr. Iqbal from the Mayo Clinic today, who will be talking to us about CAR-T and stem cell transplant for lymphoma patients, highlighting the latest advancements and outcomes in the current treatment landscape. We chose today's topic because we like to help our lymphoma community stay informed about upcoming treatment options that will impact their care. With that, we'd like to introduce today's speaker. Dr. Madiha Iqbal is a hematologist and oncologist in the blood and marrow transplant and cellular therapy programs at Mayo Clinic in Jacksonville, Florida. Dr. Iqbal completed her internal medicine residency at the University of Oklahoma in Oklahoma City. She then moved to Jacksonville, Florida, where she completed her hematology and oncology fellowship at the Mayo Clinic. She has served as a chief fellow during her training and has also been a member of the Graduate Education Committee while serving in the education chair for the Mayo Fellows Association. Dr. Iqbal is active in clinical research and has published multiple manuscripts. Outside of work, Dr. Iqbal enjoys reading, traveling, and spending time with her husband and their daughter. With that, I will turn the time over to Dr. Iqbal. And I'm going to...
and HealthTree for having me today. So I look forward to a nice discussion and hoping, can you hear me? Just to make sure. Okay.
Yes.
So I was just saying, I look forward to having a nice discussion and informing our patients. So let me go ahead and share my screen. Everything's looking good?
It looks good, thank you.
Awesome. So as Cynthia mentioned, today we'll be talking about CAR-T therapy and stem cell transplant and lymphoma patients. We'll be focusing mainly on large B-cell lymphoma, or what we commonly known as diffuse large B-cell lymphoma, and follicular lymphoma. And the reason I chose this topic is because this is where most of the innovation in the recent era has been for these particular diseases. So we'll be talking in as far as the outline, the indications, who are the patients who can receive this therapy, what is the therapy, and also what are the challenges and toxicities and other things that are relevant, obviously, from a patient perspective. So I'd like to start off by just basically deconstructing the whole thing as to what is really CAR-T cell therapy. So CAR is really what we call as stands for chimeric antigen receptor T cell therapy. And CAR is actually an artificial antigen receptor. You can see over here it's noted as CAR. So this receptor mediates recognition of the tumor. So this CAR is connected to a patient's T cells, and the combination essentially leads to what we call as CAR-T cells. So we tell patients this is a personalized kind of therapy. It's a personalized form of immunotherapy because we are taking your T cells and then modifying them by attaching this CAR, resulting in the production of CAR-T cells. Now, how do these cells work? So when your cells become the CAR-T cells, then when they are infused back into the body, the CAR-T cells go now, since they're equipped with that CAR receptor, which we talked about, they go and bind the tumor cells, and this binding is what triggers a signal transduction cascade and leads to the effective killing of the tumor cells by the capabilities of the tumor cell, the T cells, which is your immune system. If you look at the CAR-T cells, this just slide I included just to, appreciate all the progress that has gone. So this is, result of several decades of work where this was early 1900s, early 1992, 1993, with this whole idea that our immune system has the capability of curing people of cancer, but how to harness it. So currently, we are using what we call a second-generation CAR-T cells. These are the ones that are FDA approved or out in the market, but in the future, we expect, that there's going to be further modification. But you can see that almost 2 decades of work led to the first FDA approval of CAR-T cell therapy for large B-cell lymphoma and acute leukemia, lymphoblastic leukemia in 2017. So once it is determined that a patient needs CAR-T cell therapy, what does it really involve from a patient perspective? So patients undergo collection of their, of their T cells, and then from a patient perspective, it looks much like donating blood. But essentially, we're collecting your T cells, and these T cells then go to a manufacturing facility, the pharmaceutical companies that manufacture these products, and that is where these are in vitro, meaning outside of your body, are modified to generate CAR T cells. Once manufactured, depending upon the type of CAR T cell therapy that is selected by your physician, it can take anywhere from 2 to 3 weeks, sometimes even 4 weeks, for these CAR T cells to return. So patients are in a waiting pattern or a waiting time period between that time. But once they return, all patients are required to receive what we call as lymphodepletion chemotherapy. This is a chemotherapy that spans a period of 3 days. Typically, most institutes give it as an outpatient, and this chemotherapy makes CAR T cells work better. So once your T cells come, your doctors will tell you that, you will get this chemotherapy. And this starts really 5 days before your infusion of the CAR T cells. And then after that, there's a 2-day of rest. And on the 5th day, or you can call it the day 0, you will get your CAR T cells. Now, as I mentioned before, that the CAR T cell needs a target. So without a target, the CAR T cell cannot do anything. So for all the commercially available CAR T cell products that we currently have FDA approved, the target is something called as CD19. The reason this target was chosen was that this is very consistently expressed on all the lymphoma cells and the B-cell leukemia cells. So CAR T cells need some very strong and a stable target for them to do the work that we need them to do. So this picture shows you, once we started using these treatments, the dramatic response that we can expect or anticipate to see after CAR T cell, where you can see that with the black, the patient has so much of tumor, and that has all gone at 100 days after the CAR T cells. Now, talking a little, we already talked about what is CAR T cells, target and so forth. Now, moving on to which are the patients who can really get it and what are the results that we can expect from these treatments. So we had 3 clinical trials, Zuma, 1, Juliet, and Transcend, that we are showing here. And there were 3 different constructs. So you can think of it as 3 different models, essentially. They do differ a little bit in their structure, but they're essentially same target, designed to do the same job. So it's axicabtagene, tisagenlecleucel, and lisocabtagene. So these clinical trials only included patients with large cell lymphoma who had already received 2 or more chemotherapy-based treatments, and they were still having disease. So you can see that it was first tested in patient population who had already exhausted what we typically offered them for the first 2 lines of treatment. So when we look at the results, the areas that I've highlighted in the red rectangle, you can see that the patients had high response rates ranging anywhere from 50% to 83% on the higher end. And when we look at the 24 months, up at least 50% of roughly 50% of the patients were alive and free of disease. Now, it's obvious, so not all patients are cured from CAR T cell therapy, but we like to put this in perspective that before the advent of CAR T, all those patients who had failed 2 lines of chemotherapy did not have any other treatment available. And all patients were anticipated, their expected survival was 6 months. Now, out of that patients, now 50% of the patients are able to go on with their lives and, be alive. So from that landmark, it is a significant improvement, and we hope we can build on it in the future. Patients also often ask me that what will happen to the CAR T cells? Will they stay in their body? Will they go away? Will I lose their response? So studies have shown that the most important thing is for CAR T cells to do the job that we want them to do, meaning that achieve a response. CAR T cells can persist in the body for a long time, but the important thing to understand is that maintaining a response is not dependent upon having the CAR T cells still stay in the body. So persistence of the T cells or the CAR T cells in the body is not necessary for you to stay in remission. Now, going back to what we were just talking about, we also have now, like I said, the first CAR T cell therapy was approved in 2007. So we have now, close to 7 years of follow-up. And still we're saying that roughly, some patients have had a late relapse, but give and take 40% of those patients with very difficult diffuse large B-cell lymphoma or large B-cell lymphoma did not have disease. And we're now starting to call these patients as potentially cured from CAR T cell therapy. So as is the theme in oncology and cancer medicine, we try to bring our best treatments to the front, so that we can cure more patients, earlier and, expose patients to less chemotherapies. So after those 3 trials, all the same products or the same CAR T products, so it's essentially the same models of CAR T cell, were also tested in patients who received first line of treatment, which is typically R-CHOP for large B-cell lymphoma, and they still had disease or they had relapsed within 1 year. So it was a less treated population. So what we found was this, and also to highlight that most of the patients, so you can see these 3 trials, the ZUMA-7, Belinda, and Transform, testing axicabtagene, T-cell, and lysocell respectively. And so patients were randomized in these trials to the CAR T cell and the standard of care, which was chemotherapy, because that's what we do. Patients, when they get frontline treatment, they are then given more chemotherapy, and if they get a response, they go on to a stem cell transplant. Now, CAR T cell has changed that, but these are the trials that change that paradigm. So patients were randomized if they had residual disease to get after frontline treatment or early relapse to get CAR T cell therapy or standard of care chemotherapy. So all 3 trials had a similar design in that manner. And what we saw in results was this, and what I've highlighted here is this, that most of the patients in these trials were primary refractory, meaning they did not respond to their first treatment. So when we look into the results over here, you can see under the ZUMA-7 columns that the axi-cell arm did much better to the standard of care. In the Belinda trial, the results were largely similar. So the CAR T cell was not superior in this trial, but the lysocabtagene was superior. As a result of these, the FDA approved axicabtagene and lysocell also. So it was already approved for patients who had failed 2 or more lines of treatment. But as a result of these trials, axi-cell and lysocell was approved for patients who had either disease after first treatment or disease that relapsed within 12 months. This is long-term follow-up from the same studies that I just showed, and you can see that there's a wide difference in the curves in axi-cell and lysocell, but T-cell did not show superiority to chemotherapy, which is why FDA did not approve this product. So to put it in context, we do not tend to use this product now for large cell B-cell lymphoma. We tend to prefer the axi-cell and lysocell product. It was obviously not approved for the first line, so we can't use it in that. You still technically have the label to use it in the 3rd line. I also wanted to highlight this, which is the patient-reported outcomes, that these trials, they also included metrics to measure quality of life for patients who were enrolled in these trials. The Transform trial, where the patient-reported outcomes were assessed in those patients who received CAR T and those who received standard of care chemotherapy. And the patient-reported outcomes were much better in the lysocell arm, suggesting that CAR T cell therapy leads to better patient-reported outcomes and quality of life as compared to chemotherapy. The same thing was illustrated in the ZUMA-7, which was with the axi-cell, where CAR T cell therapy was associated with, you can see where we're showing p-values being significant, meaning that the CAR T cell therapy was led to a better quality of life from a patient perspective. So that's kind of in summary where we stand in terms of CAR T cell therapy for diffuse large B-cell lymphoma, with 3 products approved for patients who failed 2 lines and 2 products approved for patients who have failed first line. Currently, we do not have CAR T cell therapy approved for patients who are newly diagnosed. They still have to receive chemotherapy, but clinical trials are going to see. So we might are investigating that. So we may see some changes in that in the near future as well. Now, moving on to CAR T cell therapy for patients with follicular lymphoma. So in follicular lymphoma is a different disease as we know from diffuse large B-cell lymphoma, but patients who have already received multiple treatments for follicular lymphoma, they tend to have difficult disease. They have short time periods with limited remissions. So CAR T cell therapy was therefore investigated for patients with follicular lymphoma who had failed 2 or more lines of treatments. So the same construct, the ZUMA-7 tested the same construct, which is axi-cell, and the ELARA tested TISA cell. And you can see patients were heavily treated with an average of 3 previous lines of therapy and 4. But you can see that despite that very high response rates with 92% in the ZUMA-7, 86% in the ELARA trial, safety, we will talk about side effects in a little bit, but you can see that the high-grade side effects were on the lower side, especially for TISA cell, which only had 1% grade 3 neurotoxicity. And the third construct, same construct, so it's the same products that are being investigated. And that just goes back to the fact that all of our B-cell lymphomas, they express CD19, and it is a steady target. And then liso-cel was also evaluated in patients who had failed 2 lines of therapy. Patients with follicular lymphoma. And again, here as well, we saw very high response rates, up to 97% and CR rate of 94%. And then cytokine release syndrome, which is one of the main side effects of CAR T-cell therapy, occurred in 58% of the patients. But we worry more about high-grade side effects, but that only happened in 1%. And the neurological events happened in 15%, with high-grade happening in 2%. So as a result of this product or this construct is also now approved. This was the most recent approval in May of 24. Now, patients often ask that who can receive CAR T-cell therapy? You know, for transplant, we have a more rigorous cutoff of who to offer it because it is chemotherapy-based. But several real-world studies have shown that age, comorbidities, even if patients have cognitive or functional impairments, that does not necessarily affect post-CAR T outcomes. So we do not advise automatic exclusion of patients based on age or comorbidities. We have done several patients actually at the age of 80 years and above. So we say that transplant, being eligible for transplant, is not the same as being eligible for CAR T. And we recommend that you refer patients that are at risk, you know, older patients, you know, who have other medical problems, to a multidisciplinary clinic, preferably a tertiary facility that has sufficient experience with CAR T-cell therapy. So as I mentioned, at risk would be older patients, poor performance status, you know, or those patients who would, you know, who's somewhat compromised due to their other medical issues. So moving on to our challenges with CAR T-cell therapy. So as I mentioned briefly, patients do have to undergo a collection process. So there is that limitation. Then there is time period of waiting. During that time period, if the patient's disease is really, you know, growing or progressing and it's affecting them, and that's a problem, then we need to do some kind of bridging treatment while we're just waiting. So that's definitely a somewhat of a limitation. There's toxicities from CAR T. Affordability is a big issue, as at an average in the US, the treatment costs close to $500,000. It's mostly covered by, it has to be covered by insurance, but you know, if your insurance doesn't cover it, it's obviously affordability is a big issue. Sometimes the manufacturing can fail. It's not a very common thing, but it can happen. And sometimes, you know, because patients have received so many treatments, their immune system is not very robust, and that can affect the manufacturing of the CAR T. So those are certain issues that we deal with in the realm of CAR T-cell therapy. So cytokine release syndrome is, as I mentioned, is the most common observed side effect. It is really the response of your immune system after CAR T-cell therapy. And the symptoms or the side effect is on a spectrum. On a low end, it can range from some fevers to a higher end where patients can require ICU support with, you know, requirement of pressors or mechanical ventilation. The CRS, however, usually happens in the first week and typically peaks within the first 1 to 2 weeks. If by 10 days patients have not had CRS, we are highly do not, you know, expect it to happen. But so that's why typically over here, we monitor our patients very closely for the first 10 to 14 days, because that's where the risk is highest for these side effects to occur. If patients do have them, the treatments, there is a drug that was specifically approved, tocilizumab, to knock down or decrease the intensity of the CRS. So that drug is available at all centers who agree to give patients CAR T-cell therapy. And then we also need to use steroids if that drug does not work. So as I mentioned, this is a side effect on a spectrum. Grade 1, where you just have fever and can just manage it with Tylenol. Grade 2, where your blood pressure is falling, or you need, issues with respiration and so forth, and you require ICU support. And then grade 3 or 4 is the same, but progressing, where your need of assisted support in terms of intensive care increases. And then rarely we do encounter refractory CRS that, despite our attempts, continues. We don't know very well or understand very well. There's some clinical trials, but there are a few drugs that we have used that can help in such situations as well. And then the second side effect that we need to monitor very closely is what we call as neurotoxicity or immune effector cell associated. This is the second most common, and this is also on the spectrum, ranging from, in the early stages or in the lower end of the spectrum, patients can be just slightly confused, having difficulty counting backwards, but it can progress to the extent of where they can have seizures or, swelling in the brain and so forth. Again, this is also a side effect that tends to happen in the first 2 weeks. Though some patients can have delayed neurotoxicity during the 3rd or the 4th, but that's rare. There's also a side effect of what we call as HLH, which is like hemophage activation syndrome. Think of it as a very, very bad CRS, where the patients are very sick. It is affecting their organs. So we essentially treat it the same way as a very bad CRS or very high-end CRS. Again, it is rare, but it is one of the complications that are possible after CAR-T. So we try to prevent this. There was a study that showed that if we give some steroids on the day of the CAR-T cell therapy and for 2 days afterward, that can decrease the intensity of high-grade toxicities. So we have incorporated that. And there are a few other drugs which are currently in clinical trials, not standard of care, in an attempt to prevent the toxicity from the CAR-T cell therapy. And the newer constructs, like I showed, the lysocell, that they do have a more favorable profile where they cause less high-grade toxicity. And then another thing I like to tell patients is this, that while we focus a lot on these high-risk side effects, and they obviously happen and are important to monitor, the most common thing that happens after CAR-T is that patients do drop their blood counts. And the pattern of recovery is somewhat unpredictable, although most patients do recover within the first 30 days. But it is really the most common side effect, and we pretty much see it after all of the CAR-T cell products. As I mentioned, the duration of cytopenias is unpredictable, can range anywhere from 2 weeks to like 6 months or even longer, but most patients recover 30 days. Obviously, it becomes a major issue and can contribute to infections, need for transfusions, prolonged hospitalization, increased medical costs, and so forth. And actually, if you look at the reasons for dying from CAR-T cell therapy, the most common reason is actually infection, and not so much, the other side effects. So that's why I tell patients that after CAR-T cell therapy, it is also very important to be cognizant of infection risk and avoid exposures and so forth to prevent any serious infection to happen, because they're definitely susceptible to that. And then I also wanted to mention, like I mentioned in the beginning of the talk, about bone marrow transplant. Like, so before we had CAR-T cell therapy, patients, especially with large B-cell lymphoma, if they did not respond to frontline therapy, we would give them more chemotherapy. And this is what was evolved in the 80s, that patients, first-line therapy, we give them more chemotherapy, but what was found as a result of those studies is that it was only patients who responded to the chemotherapy, like they failed the first-line chemotherapy, but then we gave them a second-line chemotherapy and they responded to that. If those patients go on to receive a bone marrow transplant, they do better than those who do not. But that's why patients who never responded to that chemotherapy, they were never taken to transplant. So that was the population that significantly benefited from CAR-T cell therapy, as they did not have anything, that would change their disease outlook as that. So transplant, but the question is this, that now with CAR-T cell therapy, are there any patients who would get a transplant? So patients would think that, okay, now maybe everybody gets CAR-T cell therapy. So just to put that in perspective, so going back to some of the other trials that we talked about, the second-line trial where patients received either CAR-T cell therapy or transplant. And I showed a slide where it was that most of the patients had primary refractory disease in that trials, meaning they never responded to your R-CHOP, So those were patients where chemotherapy never really worked very well for them. But what about patients who respond later, more later than 1 year, Those second-line trials did not include those patients. What about those patients? Meaning that you have some sensitivity. It's not, you have obviously relapsed, so you do not have a full chemosensitivity to R-CHOP, but you still retain some chemosensitivity and you happen to have a relapse that was beyond 1 year. So there was this registry study. So CIBMTR is a registry that is built out of Wisconsin, where all the transplant centers in the United States, and I believe in some other countries too, they report their data. So this was data that was queried out of that study, that patients who respond to second line or later line treatment, and if they get transplant or they get CAR-T, who does better? So the study concluded, this is not a prospective trial, that's a retrospective, so the degree of evidence is somewhat lower here, but the study did show that the patients who have a response to second line or salvage treatment, if they receive an autologous transplant, that showed to be better or at least equivalent to CAR-T. And this was also confirmed in a multivariate analysis, which means like a more, rigorous analysis that, a transplant was not inferior to CAR-T to patients who respond. So, and the other things that are to consider is that the access to CAR-T cell therapy is still far more limited than it is for autologous transplant, in the developing countries and so forth. And what happens in the real world is this, that, if I offer patients CAR-T cell therapy, but most patients, if they're seen in the community and they relapse, their doctor will already have given them some treatment, so we can always assess, and then make our, determination based on that. So what we have been thinking here is that if patients do respond to second line, meaning that they have a delayed relapse, and they do respond to chemotherapy, transplant can be considered for those patients. And of course, there's several questions as that what one is readily available, which is preferred by the patient, what is preferred by the physician. So this is kind of the algorithm that we follow, that if you have a patient with large B-cell lymphoma or diffuse large B-cell lymphoma, we give them chemotherapy. If they do not respond or they relapse within 1 year, we give them CAR-T cell therapy. If that's not the case with them and they still relapse, meaning beyond 1 year, then we give them chemotherapy again and then assess the response to that. If they do not respond, then they get CAR-T cell therapy in the third line as per the approved indication. But if they're sensitive, then we can have a discussion of transplant versus CAR-T cell therapy. And with that, I would like to conclude and be happy to take any questions.
Perfect. Thank you so much, Dr. Iqbal. I know I learned a lot listening to the different studies and things that you brought to our attention, so thank you. So it's time for the discussion part of today's webinar. If you have any questions, now is your chance to ask those questions. This time is specifically set aside for you to talk and get some information from our incredible presenters today. So if you have any questions, go ahead and enter those in the chat. But while we wait, I just had a couple of different questions come to my mind. So let's see. One of them was what makes someone a good candidate for CAR-T over stem cell transplant, but you went over that in that flow chart, which I loved. It was a good visual to see, what the decision-making process looks like. And then let's see. There we go. We've got a question from the audience. It says, what's the main difference between CAR-T therapy and stem cell transplant? How do I know which one might be right for me?
All right. So no, that's a good question. So in some ways the processes are different, but they're in some ways similar. But to answer the question, in CAR-T cell therapy, we are using your T cells. So T cells are a part of your immune system, and these T cells are genetically modified to recognize the tumor. So that is what your CAR-T cell therapy is, and with the side effects and all that we talked about. Stem cell transplant, patients also undergo a collection process. That's where I said that the process may look a little bit similar. But over there, we're not collecting your T cells, we're collecting your stem cells. And in transplant, the treatment is not the cells. I tell patients that in transplant, what happens is this, that unlike CAR T cell therapy, like I showed that figure where patient had a lot of disease, got CAR T cell and everything cleared up. When patients go to transplant, they're already in a remission. They have already received a second-line treatment. Let's say, for example, for the sake of conversation, large B cell got second-line treatment and they have cleaned all the disease. The goal of transplant here is to consolidate the remission, meaning strengthen the remission to prevent a disease relapse, because we don't offer transplants in large B cell lymphoma in first remission because the risk is not worth the benefit. But in second line, your disease has already shown that I am a bit more aggressive, so I need a little bit more. So if I have responded, my risk of relapse is now higher. So the transplant, in essence, bone marrow transplant is always a consolidation procedure. It is unlike a salvage. CAR T cell therapy is a salvage. You're taking somebody often in active disease, where in stem cell transplant, you are consolidating the remission by using a high dose of chemotherapy. So once patients have determined, let's say, to go into a stem cell transplant, we collect their stem cells, which is like their bone marrow, not the T cells. And then when they get the transplant, they get a high dose of chemotherapy, and that is the treatment there. The stem cells are taken out of the body because a high dose of chemotherapy is going to permanently drop your bone marrow, and that obviously is not compatible with life. So in order to allow us to deliver the chemotherapy, we have to take the cells out first and then give them back after the chemotherapy. And because there are stem cells, they can repopulate the bone marrow and allow people to recover from the side effects of the chemotherapy. So in transplant, the treatment is actually chemotherapy, and the cells allow just the recovery from the effects of the chemotherapy. Hope that makes sense. So that's how, and how do I know which one might be right for you? So it really goes back to what we discussed, that if you have received 2 chemotherapies, let's say for large cell lymphoma or even for follicular lymphoma, and you still have disease after that, then that's a point to consider CAR T. And if you have a delayed relapse and you got a second-line treatment for large cells specifically, and you went into complete remission, then there is a conversation for transplant to be considered.
Okay, thank you so much. We've got another question from Dalton. He's asking, are there any health conditions that make someone a better candidate for one treatment over the other?
Yeah, so that's a good question. Obviously, we have to first take the disease into consideration. But going back to kind of the last slide I showed, where let's say you have somebody who has a relapse, right? And you gave them second-line chemotherapy, and after that, the response is probably, if not complete, maybe a little bit. And maybe you could take this person to a transplant, but you could also take them to CAR T. And that's where that kind of thing comes into consideration. So if I have an 80-year-old patient and he has had a relapse, regardless of the response to the second line, I'll probably steer that patient towards CAR T cell therapy. So we want to always kind of take into consideration, to generally put in together, comorbidities and age is a bigger factor in transplant than it is in CAR T cell therapy. That's why I showed that slide where we said that eligibility for transplant is not the same as CAR T eligibility.
Perfect. I like that slide. It really cleared some questions up in my mind, so thank you. So question from Tanya. It says, when do they take the cells out for STT, before or after the chemo? And then put them back in after chemo?
Correct. So the cells are taken out before the chemo, and then the chemotherapy is given, and then they're given after the chemotherapy. So the chemotherapy is giving you the advantage to eradicate any microscopic disease, to prevent relapse, and then the cells allow you to recover because it's a high-dose chemotherapy. It kills your bone marrow, essentially. So that's why we take the bone marrow out before, give it after the chemotherapy. It's the same cell, so there's no graft versus host disease. There's no donor involved in the autologous transplant. So it's your body, it's your cells, and they allow you to then recover from the side effects of the treatment.
Perfect. Valerie is asking if there are any specific markers or characteristics that make certain lymphoma patients more suitable for one therapy over the other.
Yeah, I think we go back to the earlier point. This is not so much as such markers, as long so if you have somebody who has disease after a frontline treatment or early relapse, take them to CAR T, because that's where our indication is. The early relapse essentially means that this person's disease is not very sensitive to chemotherapy. So to the question is that, yeah, if you have a disease biology that is clearly dictating that I am not very sensitive to chemotherapy, then those are patients that you want to do CAR T cell therapy. So if you want disease indication, and then secondly, you obviously, like I mentioned before, want to obviously keep in mind what the individual patient's, functional status, age, and all those things. So have to factor all those.
Perfect. Got another question. It says, if CAR T therapy isn't covered by insurance or isn't available where I live, what are some other great options?
Yeah, no, that's obviously a great question, and it's a fair consideration. So that's unfortunately the issue with these treatments. Access is still, and then they're very expensive as well. So that's why, transplant still has a role, So if the patients do have chemosensitivity, late relapse, respond to chemotherapy, I think transplant is much cheaper, is more widely available. So that's an option that is there. If the CAR T cell therapy isn't covered by insurance or isn't available, again, that would probably fall in the same area, because if, I guess, your insurance won't cover CAR T, it may not cover, but some of the other treatment options, let's say if a patient cannot get CAR T cell therapy, are what we call as bispecific antibodies. And these have become more recently available, actually, after the CAR T cell therapy, probably in the last 2 years or so. But these are treatments that can be given often as an outpatient on a recurring basis, and so on and so forth. And we're trying to see how they compare in terms of the cost effectiveness, because they're kind of given on an ongoing basis, right? Versus CAR T cell therapy, which is just given as a one-time, treatment. But my impression is that probably, on the long term, it might not be too different, in terms of cost. So that is a challenge, unfortunately. But if a patient has, like I mentioned, a delayed response, delayed relapse, and since still responding to some chemotherapy, like a salvage chemotherapy, then transplant becomes a, reasonable option, one time, fairly less expensive.
Okay, thank you. And for our audience that isn't as aware of bispecifics, can you talk about those just a little bit as well?
Yeah, so bispecific antibodies are also immune therapies, but here the difference is this, that we're not taking anything out of your body. These are actually over the shelf, meaning these are available drugs that can be given directly to you in the clinic. And these bispecific antibodies, but the concept is the same. They are, think of it as having like 2 hooks. When you give them inside your body, one of the hook goes to the T cells, your own T cells, and engages it, and the other hook engages to a target on the tumor cells. The bispecific antibodies we have currently approved for both diffuse large B-cell and follicular lymphoma, they target CD20, which is also a very stable target. So by engaging your T cells and the tumor, then it brings both of them together, and that causes your T cells. So again, we are relying on your immune system, but now we're not, the immune system, the T cells are sort of secondarily engaged by this third-party agent, which is your bispecific antibody.
Perfect. Thank you so much. It's always nice to hear different options that are available, especially as they're emerging. So that was wonderful. Let's see. The last question that kind of came up in my mind is I know we went through it, but just to kind of touch on it again, which line of therapy is CAR T available for in DLBCL patients and FL patients? I know there was one that was available for first line, one was available for second line.
So for diffuse large B-cell lymphoma, just to put it all together, diffuse large B-cell lymphoma in third line, we have 3 constructs that are available. So the axi-cell, tisa-cell, and lyso-cell. All of them were then investigated in the second line, but the tisa-cell did not show superiority. So it was not approved by the FDA. So 2 of them, all 3 approved in the third line, 2 of them approved in the second line for diffuse large B-cell lymphoma. For follicular lymphoma, there's no third line or second line. They were all investigated in the third line, and all of them are approved in the third line.
Okay, perfect. Well, thank you so much. So we've got a couple of participants just saying, thank you so much. Wonderful presentation, very informative. The flow charts, of course, were great because I feel like often we don't get those visuals of exactly, when things are considered. So I think that was a wonderful presentation. Thank you.
You're very welcome. Thank you for having me.
Perfect. Thank you so much. So we'll go ahead and just close out today's session. I'm gonna go ahead and share my screen again. Go. And thank you again, Dr. Iqbal. It was a pleasure having you.
Thank you for having me. Bye.
Bye-bye. All right. So before we go, I wanted to highlight how to connect your records in HealthTree Cure Hub. After creating a HealthTree Cure Hub account, you'll be able to electronically connect your health records from any facility into your profile. Once your records are connected, you can now view a comprehensive overview of your medical history, including diagnoses, genetics, lab results, and treatments, all within a single user-friendly interface. It takes only a few minutes to create the connection and to start taking control of your diagnosis. On the screen, I have the link to sign up for HealthTree Cure Hub, along with the email address for our amazing patient navigators who are available to help you create an account and connect your records. I'll, of course, also include this information in our follow-up email, so keep an eye out for that. As you leave today's session, we would appreciate you taking 2 to 3 minutes to fill out a brief survey about your experience during today's event. So please take a moment to do that. And here are our upcoming events. On Tuesday, November 5th at 1 p.m., we have a webinar on estate and legacy planning for blood cancer patients. The title is Protect Your Future and Leave a Lasting Impact. And then our next DLBCL and Follicular Lymphoma webinar will be on Tuesday, November 19th at 5 p.m. Eastern. And we'll be hearing about how to improve communication with your healthcare team and make informed decisions as a lymphoma patient. And we have many more virtual and in-person events in the works, so stay tuned. And we will send out links to sign up for these and many more events in our follow-up email. I would like again to thank our sponsors, Regeneron and Bristol Myers Squibb. And finally, of course, I just want to thank you for helping us build a strong DLBCL and follicular lymphoma community. I've added my email to this slide, so please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate you all and hope you have a great rest of your day and hope to see you again soon.